Okay. Good afternoon. My name is Jirayu, and today we're presenting our research entitled CBCT Study of Partial Mucosal Thickness Variation in Maxillary First Premolar in a Group of Time. Here you see outline of our presentation. Gingival recession is one of the most common periodontal conditions. Gingival recession is a movement of the gingival margin from segmental junction to the apical aspect of the tooth. Gingival recession is associated with several causative factors such as traumatic tooth brushing or periodontal disease. Recession of the gingival margin is an aesthetic concern, sometimes associated with dental hypersensitivity, and patients often requested a treatment to resolve this. Therefore, root coverage has been attempted with different types of mucogingival surgery. The palatal masticatory mucosa is widely used as an autologous connective tissue donor site in periodontal plastic surgery for gingival recession treatment. This is essential therapeutic tool in mucogingival periodontal surgery from functional and aesthetical perspective. Harvesting of palatal mucosal graft has been shown in picture 2. The most common area for harvesting palatal donor tissues was involved first premolar to first molar area. Subepithelial connective tissue graft is one of the mucogingival surgery for coping denuded root surfaces, which has been reported high success rate and high aesthetical result. The post-treatment after subepithelial connective tissue graft is shown in picture 4. Graft thickness and volume are important factors to determine appropriate treatment and prognosis. Thus, an adequate graft dimension is required for obtaining ideal result. So our study aim is to assess the palatal mucosal thickness of maxillary first premolar. For our material and method, we review patient cone beam computed tomography images, which was approved by University Ethical Board. Our 916 CBCT images taken from the year 2008 to 2020. There were only 20 patient CBCT images, 10 males and 10 females with full permanent maxillary posterior teeth, and absence of scattered artifacts could be included in this retrospective study. All of them were recruited from Department of Radiology, College of Dental Medicine, Frankfurt University, which is purposive sampling. The inclusion criteria includes healthy participants aged between 21 to 80 years old, presence of all maxillary posterior teeth, and fully erupted. And exclusion criteria includes severe crowding or rotation in maxilla, history of palatal surgery in maxilla, lesion in maxilla. Our hypothesis that we came up with is whether there is a difference of palatal mucosal thickness between left and right side. This figure shows the coronal plane of maxillary arch, which we draw on a 3 mm interval section line along the palatal mucosal outline, 3, 6, and 9, and 12 mm, starting from CJ. Then the mucosal thickness was recorded at each point by the distance measure from palatal bone perpendicular to palatal mucosal. This figure shows CBCT image in coronal plane with palatal mucosal thickness assessed at 3, 6, 9, and 12 mm. In statistical analysis, to test the inter-implant reliability of palatal mucosal thickness, we use interclass correlation coefficient, and it was greater than 0.9, which indicates perfect correlation. Then homogeneous smell test was used and showed that the data had normal distribution. One way ANOVA was used to compare the mean of palatal mucosal thickness at the same site. If there were significant differences, the 30-type post-hoc test will be used to adjust the pair were significantly different. Next, independent t-test was used to determine the difference of palatal mucosal thickness between gender. Finally, pair t-test has been used to be determine symmetry of palatal mucosal thickness between left and right side. Here is the result and discussion. From our study, we found that there were no statistically significant difference of palatal mucosal thickness between male and female, and palatal mucosal thickness were symmetric between left and right side. This diagram shows the mean and range of palatal mucosal thickness, which x-axis represent left and right side of maxillary first premolar, and y-axis represent the thickness of soft tissue in millimeters. And different color of graph represented the different distance from CJ to measurement point. In our study, thickness tend to be increased from coronal to apical region 3, 6, 9. However, decrease in the thickness at 12 millimeters was observed, which is consistent with the study of Ueno which conducted in Japanese population. However, our result was inconsistent with the study of Song which performed in Korean population. Palatal mucosal thickness was reported of no decline of palatal mucosal thickness at 12 millimeters. The mean thickness of the right side was 3.63 millimeters and the left side was 4 millimeters. This table shows the mean palatal mucosal thickness with standard deviation at 3, 6, 9, 12 millimeters from left and right side of maxillary first premolar. In our study, the maximum soft tissue thickness was at 9 millimeters and thickness at 3 millimeters on both left and right side. In many studies, the palatal mucosal thickness increased gradually from CJ towards the apical region, which correlated with our study. What may suggest that the minimum thickness of palatal mucosal graft should be at least 2 millimeters for covering the gingival recession and improving the success rate of palatal soft tissue grafting. According to our study, an adequate quantity of palatal mucosal thickness can be acquired from area 3 to 9 millimeters below CJ from the first premolar. In conclusion, the palatal mucosal thickness were consistent on both sides, which were not affected by gender. In addition, the palatal mucosal thickness were increased gradually from CJ towards the apical region. An adequate quantity of palatal mucosal thickness can be acquired from area 3 to 9 millimeters below CJ from the first premolar area. There were also limitations in our study, especially small sample sizes, since most of CBCT show the overlapping of tongue and palatal mucosa. Therefore, the thickness could not be accurately assessed and has to be excluded. We suggest that the further study should include larger sample size and variation to position, such as molar teeth, so we can determine the maximum dimension of palatal mucosal graft. We would like to express our thanks and gratitude for your attention. Thank you. ขอบคุณครับ
Okay, thank you, Dr. Jirayu, for a lovely presentation. This is a very interesting topic. Any other questions from participants are welcome.
Hello. Your study reported that the palatal mucosal thickness increased from coronal to apical region at 3, 6, 9 and decreased in thickness at 12 millimeters. Can you explain or discuss why palatal mucosal thickness decreases at 12 millimeters point, please?
Okay, thank you for the good question. The thickness at 12 millimeters were different in ethnicity. The mucosal thickness increased from 3, 6, and 9 millimeters and decreased at 12 millimeters was reported in Ueno studies. And so in Japanese population which consistent in our study. So there is some ethnicity difference.
Okay.
Thank you.
Is there other questions? Okay. If so, I have a very quick one. I would like to know why you focus on the area of first premolar.
So due to our limitations and sample sizes, so as we said before, the CBCT is limited when the tongue and palatal soft tissue is overlapping. So as we concluded, when CBCT images is not overlapping, only 20 sample sizes can be conducted. So mostly the CBCT of tongue and palatal surface tissue images that not overlapping is at first premolar area. So we use that.
Okay, I see. Okay, thank you very much for your presentation. Let's move on to the next one, shall we?